Hi, I'm Schell. I'm one of the spine fellows here at Swedish. Thanks for tuning in and checking out my presentation. We try to develop a classification here at Swedish as part of my research project, so I really appreciate everybody's help going through the cases we're about to present and testing it out, so we'll get right to it. So the original purpose of the classification, we decided there's no real consistent nomenclature for these multiple rod constructs. We do a fair bit of them here at Swedish. We try to use them, only when they're indicated, and we discovered that there was a smattering in the literature, and we needed to be able to discuss them amongst the colleagues here at Swedish, other institutions, generally using the same nomenclature throughout and the same descriptive terminology so that we could all be talking about the same thing. To avoid constructs like this, where the rods don't seem to really have a purpose, they may or may not be holding on to the main construct, and so the overall goal of the project was to develop this multiple rod classification system and a universal nomenclature so that we could all be speaking the same language. After a Delphi process, we came up with some different terminology that we'll get to in a second, but we ultimately ended up calling our system the MROCS, the Multiple Rod Construct Classification System. And these are the main criteria that we used when looking at these different constructs that we'll go through here in a second. So the number of rods, the rostral-most extension of the fusion construct, and then the working rod, and then the pelvic fixation. And so the spanning rod and the working rod are the two main rods in these constructs. And then that's kind of the terminology we'll be using throughout the presentation and hopefully throughout the spinal literature going forward. So here's an example case that we'll just kind of walk through, show you how to go through the cases here in a second and then through the video. So each arm of the classification system can be answered through plain film x-rays or scout films on a CT scan. And so we'll stick with those throughout the rest of the cases. So the first question is how many rods are present? And you can see through here through the red numbers. You have rods 1, 2, 3, and 4. We do not count end-to-end connectors. We try to use them as biomechanic constructs. So in this particular case, there are 4 rods. We also don't count the cross connectors as well. So 4 main rods in this particular case. So we've answered that question. Going on to the next, how far rostral does the spanning construct work? So it may not project well, but T9 vertebrae is marked. So that means in this particular case, T10 is the most rostral portion of this construct. And so that level T10 corresponds to a numbered section of the spinal column seen on the previous slide. And so that will be the number 3. So right now we're at a 43 because we have 4 rods, and this T10 construct corresponds to the 3rd spinal section, thoracolumbar junction. Then the next question is, what is the indication for the working rod, for the multiple rods? And so this is determined through excerpts of the op note, which we will include through all these cases here in just a second. This particular case, there was a pseudoarthrosis at L5S1. And so their pseudoarthrosis corresponds to a P, the letter P in the classification system. So far we're at a 43P. The next question we ask is how much fixation is in the pelvis. If greater than 2 screws are used to affix it to the pelvis, a simple plus is added to the construct. If there's only 2 screws, then the classification stops right there. So in this particular case, it's a 43P. So 43P gets us to the pelvis. So this is a typical case that we'll be seeing here in the next couple slides. So we have a 56-year-old woman. She had a post-attempted fusion with the pseudoarthrosis at L5S1, and that gives us a 43P because she had 4 rods. The rostral-most portion of the construct went to T10, so that corresponds to a 3. The procedure was done for a pseudoarthrosis, so it gets it to a P, 43P, and then she has the plus, which is how much fixation is actually into the pelvis. So this is that same case, showing how I walk through the flow chart. So again, we've got 4 rods. The rostral-most portion of the construct goes to T10, so that'll show you corresponds to a 3. It was done for a pseudoarthrosis, which is a P. And then we have greater than 2 screws, so she gets a plus. So 43P plus for this particular construct. And And so we will slowly walk through these examples as we go forward. So here's a, there we go. Sorry, it's been a little slow up here. There we go. Now, here's an example of the MROC's classification with the 4 main questions that we ask each one of these x-rays that you're about to see in the Scout CT films. And so when you go through these here in the next video, feel free to pause the video, feel free to skip around, feel free to reference this chart here on slide 13, and depending on how it's actually arranged for your video at home, and we will hopefully be able to access this, and it will become more routine as you use it and go through. None of the answers are shown to these next cases in the PowerPoint, so you won't make a mistake and accidentally find them and bias your judgment. I hope not. And so we'll attach a survey link to be able to input your answers, and we'll be able to collect the data here going forward. So here we'll get to it. There are 20 cases, so feel free to slow me down or speed it up depending on how much time you have to finish this. Either way, I appreciate it. So the first case here is a 68-year-old woman. She had pseudoarthrosis at L4 to S1, and this was the construct that was used to stabilize her. I'll give you guys a couple seconds, take a look at it. All right, and the next one here, 74-year-old man with the pseudoarthrosis at L1-2, and you can see there on the lateral that the T1 vertebra is marked. I know it gets a little hazy there on the lateral and on the AP to see how far up the construct extends, but T1 is marked there above the construct. Case number 3 is a 58-year-old man. He had Charcot-arthropathy, and we, again, used this multi-rod construct, and you can see where the vertebral levels are marked above, there on the right. All right, case number 4, 71-year-old woman. She had trauma. So she had this AOB3 fracture at the L2 vertebrae. All right, case number 5, 74-year-old man had decompensated kyphoscoliosis. Again, those are all pulled from the op notes. And then you have the Scout AP CT scan with the T3 vertebrae marked above the construct. All right, case number 6, 72-year-old man again with osteoarthrosis, with the T3 shown marked above the construct there. And then case number 7, 72-year-old man with osteoarthrosis at L5S1. And his films didn't extend up high enough for us to mark the level above, so the T10 level is marked there on the AP and lateral. And then case number 8, she was it's a 71-year-old woman. She had a Charcot-arthropathy after some Harrington rods, and the T9 vertebral level is marked there on the right. And then here on the number 9 case, 43-year-old woman, she had metastatic breast cancer, so she had a pathologic fracture down her low lumbar spine and sacrum, and then has L3 marked there on the films. All right, case number 10, halfway there. 74-year-old woman, again, had a non-union there at L5S1, and then has the T10 vertebra level marked on her scans. Case number 11, 71-year-old woman, had some degen scoli, the T7 vertebral level marked. Case number 12, 53-year-old woman, again, metastatic cancer with pathologic fracture in her sacrum. Case number 13, a 56-year-old woman with a pseudoarthrosis, has T9 marked there on the AP and lateral. Case number 14, 72-year-old man has pseudoarthrosis again, and maybe a little tough to tell on that lateral, but the T4 level is marked on the lateral. Case number 15 is a 47-year-old woman, kyphoscoliosis, and then has the T3 level marked on her lateral. Case number 16, 56-year-old woman with a pseudoarthrosis and has the T3 level marked on her AP and lateral. Case number 17, it's a 70-year-old woman with neuromuscular kyphoscoliosis, has the T8 level marked on the AP and lateral there. Case number 18, 73-year-old man with kyphoscoliosis, has the T10 level marked. Case number 19 is a 46-year-old man with she had some osteomyelitis infection there, lumbar spine, and you see the L4 level marked. And then last but not least, 20-year-old, case number 20, 71-year-old man with degenerative scoliosis. And you see there on the lateral and on the AP, I hope it projects well, the T9 level is marked. Things get a little blurry down in the lumbosacral junction on that lateral scout CT, but hopefully things are making out well there. All right, well, that's it. Those are all 20 cases. Again, I'm Ben Schell. I'm one of the spine fellows here at Swedish. Really appreciate you taking the time, take a look at the cases. Again, there'll be a survey link attached so we can get your responses on how you're classifying these, and hopefully we can release this into the spine literature and hopefully get a common language and a common classification system for these multi-rod constructs that are becoming more and more common these days. So we'll jump back. Forgive me, I'll click back and I'll show you the flow chart one more time, kind of refresh everybody's memory. Here are all the questions, again, number of rods. So, the flow chart itself there just goes from 3 to 6, but however many rods are there, 2 all the way up to, single digits would hopefully, we haven't seen any yet that are above 6, but I'm sure they're out there. Then the rostral-most fusion of the spanning rod, we're calling that the spanning rod that spans the area of concern. And then the working rod reason would be the, the main indication for the surgery would be, listed there: deformity, pseudoarthrosis, infection, or tumor, neuropathic spines or trauma. And then that bottom one there is the pelvic fixation, how it's affixed to the pelvis. So the, questions there hopefully lead us to a more common classification, more common language throughout the spine literature, and look forward to hearing your responses. So thanks so much. Have a good day.